Right. Good afternoon, everyone. Thank you for joining us today. Welcome to Department of Medicine Grand Rounds. Before moving on to the introduction for today's speaker, I would like to share a few housekeeping items. For the in-person audience, if you have a question at the end of presentation, please press and hold the microphone in front of you so that the virtual audience can hear you. For the virtual audience, please keep your microphone muted. You can post your questions in the Q&A chat and we'll address them at the end of presentation. CME code will be shared at the end of presentation, and you can claim your credit by logging on to EVMS CME website. With this, it is my honor to introduce today's speaker, Dr. Nasim Wiegley. Dr. Wiegley is an associate professor of medicine in the Division of Nephrology at the University of California, Davis School of Medicine, where she also serves as the Nephrology Fellowship Program Director. She is additionally the founder and director of the Glomerular Disease Clinic at UC Davis, which has grown into a regional referral center for patients with complex and challenging glomerular diseases. Dr. Wiegley completed her internal medicine residency at the University of Illinois College of Medicine at Peoria, where she also served as chief resident, reflecting her early and sustained commitment to medical education and leadership. She then pursued fellowship training in nephrology at UC Davis, followed by advanced subspecialty training in glomerular diseases through the Glomerular Disease Study and Trial Consortium, or GLOMCON. Her academic career is defined by a rare combination of clinical excellence, educational leadership, and scholarly productivity. As Fellowship Program Director, she plays a central role in shaping the next generation of nephrologists and holds multiple educational and quality-focused leadership roles within her institution. Nationally, she is widely recognized through her role as editor-in-chief of GLOMCON Publications, where she leads a major educational platform dedicated to advancing knowledge, mentorship, and innovation in GN care. Dr. Wiegley's scholarly work is both extensive and impactful. She has authored numerous peer-reviewed publications, review articles, and book chapters spanning lupus nephritis, IgA nephropathy, membranous nephropathy, FSGS, and emerging therapeutics in glomerular disease. Please join me in welcoming Dr. Nasim Wiegley, and she's going to speak to us about the evolving landscape of lupus nephritis, diagnosis, and management. Over to you, Nasim, and thank you so much for joining us.
Thank you. Thank you for that warm welcome and the invitation to speak about glomerular diseases. I never get enough about talking about glomerular diseases, and in particular, lupus nephritis holds a very special place in my heart. So thank you for giving me the opportunity. And I'm very excited to hear that we might actually have your nephrology fellows in the room as well. That's a wonderful addition that I was not expecting. That's great. For sake of time, I'll just move forward. Again, as you mentioned, I'm going to speak on the evolving landscape of lupus nephritis diagnosis and management. And that's really because this field is advancing so rapidly that I think every couple of years, there needs to be kind of a regrouping to determine the standard of care at that moment in time, knowing that that's very likely going to change. So what I'm going to talk about today is really based on the available evidence that we have in early 2026, which very likely will go move forward to actually change as we even speak. I do have my disclosures here. I'm hoping that you'll find the slides and the presentation unbiased. I am the local PI for some of the glomerular diseases, including one for lupus nephritis at UC Davis. But again, I'm hoping that you'll find the slides and the presentation unbiased. And what I'm going to talk about today is just going to be very overall simple, a very brief overview of the epidemiology of lupus nephritis and why is it that we even need to talk about it to the length that we're going to talk about with the impact that it has on the global healthcare systems. A brief overview of various lupus nephritis cases as far as like pathophysiology goes. And then I really would like to actually spend most of the time on management. And the management discussion is going to be also case-based. So just a very brief overview. Again, as you're all aware, lupus itself is the prevalence and incidence are actually increasing because of a variety of reasons, because of pollution, because of environmental exposure to things that our bodies actually respond to by autoimmunity and kind of overall leading to some genetic variations as well. Of the individuals with SLE, approximately about 50 to 60% develop lupus nephritis throughout their lifetime. Oftentimes, this actually is in close proximity to the initial diagnosis of their SLE. Sometimes, actually, as nephrologists, we identify lupus nephritis, which would be the first manifestation of the patient's SLE. Sometimes they actually are known patients with lupus and lupus nephritis that manifests afterward. Again, as I mentioned, this is very often close to the proximity of their diagnosis of lupus, but it could also be delayed manifestation of the kidney involvement even months to years later. Unfortunately, despite all of the advancement in our field, approximately 10 to 30% of the patients with lupus nephritis still progress to kidney failure, needing transplantation and kidney replacement therapy discussions, and hoping that within the next 5 to 10 years or so, we can actually change these outcomes by some of the investigational therapeutics that are currently in investigation. One thing that I really wanted to note here is that for the longest time, we continue to say that men have a lower risk of developing lupus nephritis. But when they do, they actually have a more aggressive disease phenotypic presentation. Well, that's no longer the case based on some of the newer evidence that came out in late 2025. And so I just really wanted to highlight that we're identifying that more and more of the recent observational and kind of epidemiologic data show that men with SLE and lupus nephritis also have a very similar disease phenotypic presentation compared to women. As far as the ethnicities that are at higher risk, so in the United States, so in kind of like the Western population, patients with Black, Hispanic, or Asian ethnicities have a higher risk of developing lupus nephritis compared to the white counterparts. And unfortunately, they tend to have a more aggressive disease phenotypic presentation. Now, there are a lot of discussions about what causes that difference in their response to treatment. It could be from socioeconomic aspects and delayed access to care. It could also be from some genetic variations, for example, the APOL1 gene that is, of course, more prevalent in patients of African descent. As far as what we can do to improve outcomes going forward, if you see the graph on the right, it really shows that every episode of lupus nephritis unfortunately leads to a degree of nephron loss that we may no longer be able to gain back. So the episodes of flare are what we really need to target to prevent, even in somebody that actually gets kidney involvement with their lupus. So they actually develop lupus nephritis or a different variation of kidney involvement related to their SLE. If we can actually identify how we can prevent the relapses and flares going forward, we can hopefully prevent nephron loss in addition throughout the lifespan of that individual. Because as you can see, compared to an age-appropriate person for just the kind of generic age-appropriate nephron loss, every episode of SLE leads to a significant nephron loss that just progresses towards CKD and ESKD going forward. So a little bit about why SLE is so difficult to manage. And it's really because, unfortunately, something triggers the release of these immunostimulatory nuclear components, so these double-stranded DNAs. Something releases those in the systemic circulation. And that could be, again, an environmental exposure, something that really triggers this quiescent immune dysregulation that was previously present, but a second hit awakens that. So it could be something like that. It could be an environmental exposure. It could be just a generic variation that an infection can actually bring into surface. But again, a second hit mechanism usually awakens this immune dysregulation. And then the B cells lose tolerance to self-antigen. So the B cells get activated through this mechanism. Of course, the T cell activation is another part of it. So the main cellular activation is really something that becomes an integral, central part of this entire cascade of inflammatory response that then continues to move forward. And by that moving forward, I mean that these B cells move on to become plasma cells. Plasma cells can become memory plasma cells and long-lived plasma cells that actually live in bone marrow and can continue to progress to produce those autoantibodies. And these are very difficult to target from a therapeutic perspective. When they become those long-lived plasma cells, these are very challenging to target and get rid of. And then another aspect of the activity of the kind of pathophysiology of lupus nephritis is what happens at the kidney tissue level. So in the systemic circulation, there's all of these inflammatory cascade of events happening, but then these immune complexes go and get deposited in various parts of the glomeruli, and that by itself initiates this other cascade of events that very often brings in the complement system and other local tissue level activity that then becomes very injurious to the local nephrons and leads to that nephron loss. So with all of that, we know that the therapeutics that we need to develop to target and control disease activity in somebody with lupus, and by that I also mean lupus nephritis, the therapeutics then very often need to be multi-targeted. So as you see throughout this talk, a lot of the times I'm going to talk about add-on therapeutics on top of each other to really target various aspects of this immune system. So even with all of that, as you know, and we talked about right now, the outcomes in these individuals is poor, and many still progress to kidney failure and need for transplantation or dialysis initiation. And so one of the major factors is early detection. So how can we all collaborate to identify these individuals at risk of having lupus with kidney involvement? And a lot of that is going to be up to the individuals that see those patients upfront, either in the hospital setting or in clinic. So a lot of the times, primary care physicians are that first group of individuals that see these individuals at risk of kidney involvement. And so what are some of the times that would be very appropriate for nephrology clinic referral or in the hospital for consultation? And those are for patients that, of course, have an autoimmune disorder, but then you identify that they're starting to develop hematuria. Now, of course, not every hematuria is glomerular hematuria. And so we always ask for first repeating the sample, especially if that's a young woman of age, from an age perspective, still menstruating, confirming that they're not on their menstrual cycle, confirming that it's not a bladder infection and, hematuria related to that. But then if those are ruled out and the hematuria is persisting, definitely identifying if that's associated with proteinuria, another major aspect of it. Because a hematuria that's accompanied by proteinuria, and by that I also mean albuminuria, is of great concern for glomerular filtration barrier injury. And so these are glomerular filtration barriers that have been injured because of that inflammatory response at the local kidney tissue level. And then these RBCs, of course, are squeezed through. They form blebs. They actually have that dysregulation, that acanthocyte formation. And these are what we can actually identify on urine microscopy. Majority of nephrology clinics definitely have urine microscopy stations in the clinic. So these are very easily detected by us in the clinic setting. And again, on the proteinuria side, we very often request a kind of combination of quantifying urine total protein to creatinine ratio as well as albumin to creatinine ratio, because if that total protein excretion per day is elevated, but it's not albumin primarily, well, that could be overflow proteinuria, it could be Benz-Jones proteinuria, it could be a lot of different things, but my concern for glomerular injury would go lower. But on the other hand, if that total proteinuria is accompanied by over about 40 to 50% albuminuria, well, now I get concerned that there is actual glomerular pathology happening too. And so these are, again, some of the times that I really would emphasize early referral to nephrology, because the sooner we identify these individuals, the better chance we have to quiescent that inflammatory response and regain the nephrons that have been initiated on the kind of like their path towards injury and prevent that total nephron loss. Another thing that I really wanted to mention is this terminology of silent lupus nephritis. And the silent lupus nephritis very often comes up in our kind of diagnostic pathways because at the moment, majority of the guidelines are very focused on this proteinuria-centric diagnostic pathway, that if proteinuria is more than 500, consider kidney biopsy and referral to nephrology. If the proteinuria is less than that, there's this notion that those are patients not at intense risk, but that's not really true. So there are individuals with silent lupus nephritis that evidence has shown that about 30 to 40% of individuals with silent LN can actually have class 3 lupus nephritis on biopsy. These are just undetectable on like biomarkers such as urine protein excretion because there actually might be accompanying other structural changes. For example, somebody who's actually having kidney function decline, maybe with some RBCs in the urine, but the proteinuria is less than half a gram. Well, that patient is at high risk of actually having, for example, lupus vasculitis, which is another major concern for kidney involvement in the setting of lupus. It's just, it might not be to the degree of podocyte injury and the proteinuria may not be to that degree, but that doesn't mean that there is still no concern for kidney involvement. So a lot of the times, again, if you detect even a lower grade proteinuria, if that's accompanied by other high-risk features such as hypocomplementemia and elevated double-stranded DNA antibodies, those are individuals that, again, I would recommend early referrals to nephrology. But then from now on, I would like to actually focus on these two cases. So one case is going to be a little bit more of a kind of like clinic type patient. So low grade subnephrotic range proteinuria, somebody that again very often could be seen in primary care clinics, stable kidney function, but still with high risk features that I'll show you. And then another patient definitely having more degree of proteinuria, more RBCs, declining kidney function. That concern, your gut feeling is telling you this is going towards RPGN pattern. And so again, these are the two very clear, very classic presentations of lupus nephritis that are very different from a therapeutic perspective. So the first patient, and these are patients that I've modified the presentation slightly for patient privacy, but these are actually from our glomerular clinic. So this patient was a 28-year-old Hispanic woman who presented to her PCP with 3 months of symptomatic polyarthralgia affecting her PIPs, MCPs. She had some morning stiffness in her hands, and she reported a persistent bilateral malar rash that worsened with sun exposure. So a lot of high-risk things are coming out of that. 2 months ago, she developed fatigue and malaise, and she was 28 years old with one child, and so she thought that, again, the fatigue and malaise are just because of how busy she is in life. So she didn't see anybody at that point. In the clinic, exam and workup showed a non-erosive joint swelling, classic malar rash, sparing nasolabial folds. So that kind of classic look of a malar rash that would go with an SLE. And then vital signs actually in the clinic were normal. So she's currently on oral contraceptive pills, no other known medical history, and she has a maternal aunt with rheumatoid arthritis. So at the time of that initial presentation to her PCP, the workup showed a normal CBC. In her UA in the clinic, she had 2+ protein. She had some RBCs, some WBCs. And the kind of flag from the UA that kind of is automated read by the machine later showed no casts that were reported. And of course, the primary care physician was very concerned about an autoimmune concern. And so an initial workup was started that showed elevated ANA, of course, with positive double-stranded DNA, positive anti-Smith DNA. So a lot of concern for lupus was starting here. Even though the aunt had RA, so at this point with these laboratory workup, a lot of concern for SLE was starting, and also with the malar rash that she had. And so she was referred to the nephrology clinic very appropriately. And as you can see on the right side, her urine studies show the UPCR, so urine total protein to creatinine ratio of 0.85 gram per gram, and that's 850 milligram per gram. And her urine albumin to creatinine ratio was actually quite significantly high, definitely over that kind of 50% threshold that we start to get concerned about glomerular pathology. And that was about 720 milligram per gram. At the nephrology clinic, a 24-hour urine was done, and that actually by then was 1.2 gram per day, and she continued to have some RBCs. And so when I work with our fellows in the glomerular clinic, the first few questions that we always have is the utility of urine microscopy in this case. When do we biopsy this individual? And already starting to think about our therapeutic approach, because many of these medications need a lot of consultation with the patient, making sure that we're all on the same page for shared therapeutic decision making. And so already from that first interaction, we're starting to think about some therapeutic options, so that when we have the biopsy results, we can easily move forward to urgent management. So for this patient, of course, urine microscopy, which is kind of our liquid biopsy, is really the next step, just to confirm that these are truly glomerular hematuria RBCs. These are concerning for that, again, damage to the glomerular filtration barrier and acanthocyte formation. And as you see, I don't know if you can see my cursor here, but like this is an acanthocyte. This one's an acanthocyte here. This one's clearly an acanthocyte. So all of these with blebs, and this sample was full of this. And our nephrology fellows get very well trained in clearly ruling out mimickers of acanthocytes, and identifying true acanthocytes, so that then we can move forward to considering the biopsy. So in a patient with lupus, when do we consider kidney biopsy? And there are a lot of different moments, different forks, kind of like in decision making in the lifespan of a patient with kidney involvement in the setting of lupus, that we think about doing a kidney biopsy. So of course, upfront at the moment of that initial presentation, if the patient has not been diagnosed with lupus nephritis before, we very often move forward with actually getting a kidney biopsy. It would be extremely rare for us to say we don't need a kidney biopsy, because again, lupus can have different flavors, different faces, and I'll show you a little bit of that, but also it could actually be a lot of other aspects beyond glomeruli that could be involved, and only the biopsy would differentiate that for us. And so at the moment of diagnosis, we move forward with a biopsy, even if there are no major contraindications. And then throughout the treatment plan, if the patient doesn't have the response that we expect, sometimes we actually do a biopsy after about 12 to 18 months to see why is it all scar tissue, and we no longer would anticipate a response to immunosuppression, or is there still very active tissue level involvement, and it just signals a need for change in therapeutic plans. Also during moments of flare, a lot of the times we actually think about, do we need a biopsy, and would that change management? And very often in select individuals, even before withdrawal of immunosuppression, at the end of their maintenance phase, we still consider a kidney biopsy, just to make sure that histologic activity is matching their biomarkers. So as far as, the kind of classic teaching about lupus nephritis, for all the residents and fellows in the room, you've very likely heard about this in your medical school. So I'll just very briefly review this, but I would highlight that a lot of us as nephrologists and glomerular disease practitioners, we're not the biggest fan of this classification, because it really highlights just how glomerulocentric we've become, because we're not really at this point with this classification, which is always taught, and kind of the conversation about lupus pathology stops there. We don't think about the vasculature, because again, lupus vasculitis is a big concern. Lupus podocytopathy, which is just the podocytes being injured and effaced and separated from the GBM, but the rest of the structure is pristine and clean. So all of those are not addressed within this classification. So the classification of lupus nephritis might change in the coming years, but this is what we have at the moment. So there are these 6 classes. Class 1, as you can see, very often doesn't really have any significant glomerular change, at least on the light microscopy. So usually these individuals end up getting biopsied for ATN or for something else, or for like lupus vasculitis, for example, and then just the gloms actually are looking pretty good. Class 2 is when there is mesangial involvement. And other than that, the capillary loops are still nice and open, and the flow through these capillaries is still completely preserved. Class 3 and 4, very often in the kind of pathologic side of things, they're differentiated from each other, but from a clinician nephrologist, for me, they're about identical from a therapeutic perspective. The main differentiating factor at the moment from a pathology is from the sample that was identified, the number of glomeruli that were in that sample, are there less than 50% involved with that inflammatory response and hypercellularity in these endocapillary spaces, or more than 50% of the glomeruli are involved? And so, like, from a pathologist perspective, like, there is apparently a differentiation between a kidney that has like 45% of the gloms involved as opposed to like 55%. But from a clinician perspective, these are identical. They're both very proliferative, very hypercellular, very active from an inflammatory perspective. And so we treat those identically. And then class 5 really has its own flavor. It's completely different. It can present with 3 or 4 or 2 even, or it can be solo as its own presentation. It's very similar in its characteristic of when the patients present, very similar to membranous nephropathy. So these patients have significant nephrotic syndrome, very low serum albumin levels, usually accompanied by high blood pressure, hyperlipidemia, all of the things that you would see in a classic nephrotic syndrome. Class 5 patients have that. And the response to treatment is very variable. So it's kind of like the class that we know about the least. And then class 6 is just for textbooks and board exams. In reality, we never really see class 6 because as a clinician, we know enough about when to expect that this kidney is essentially burnt out. And those individuals we do not biopsy. So it's kind of on a biopsy, we never really see class 6. This is something that I really want everyone to be aware of, especially for nephrology fellows in the room. You're aware of this. So in 2018, that original classification got modified a little bit, still kept with that glomerulocentric focus from a classification perspective, but they added these activity index and chronicity indices that you don't have to, of course, memorize. I just want you to know that sometimes if your nephrologists are saying that this individual, for example, does not warrant immunosuppression at this point, maybe they're looking at that high chronicity index. So the activity index shows us how active that kidney tissue sample is right now at that snapshot moment of the biopsy, as opposed to the chronicity index showing us about the scar tissue that will never respond to immunosuppression. So in my practice, if I see somebody with low activity index, unfortunately, and a very high chronicity index, there are times that we actually forego immunosuppression at that point because I know this patient will never respond to that immunosuppression and they're heading towards kidney transplant need. And I want to preserve that body's ability to tolerate years of immunosuppression when they get their transplant. So again, there are different information pieces that we can get from activity index and chronicity index. And we do actually bring this information into our therapeutic decision-making quite a lot. So going back to the patient in case 2, that individual, this is the biopsy that we would have gotten. Again, these are kind of identified biopsy pieces with arrows and whatnot for education purposes. But the patient's biopsy actually did show these mesangial areas. As if you see my cursor, these are the areas of the mesangium. And as you see the capillary loops, these other areas that I'm showing you now, these are nice and open, and flow of blood through them is not limited because of white blood cells being there. And so these are, again, not endocapillary involvement, and only you see the mesangial matrix expansion. So that area of pinkness in between the capillary loops is expanded, and you see more pink there than would be normal. And the number of cells usually there are expected to be 3 to 4, and you definitely see more than that in these in the sample. So this individual was diagnosed with class 2 lupus nephritis. And I just wanted to very briefly talk a little bit about the management of class 2, and some of this actually comes to all of the classes of lupus nephritis. And those are the things that, again, are common for, again, all of our patients, and then we'll talk about class 2 in particular. But in all of our patients with lupus and lupus nephritis for sure, if the patient's not contraindicated to have anti-malarial therapy initiated, we absolutely want the anti-malarial started as soon as possible. These are medications that, of course, in the US, we use hydroxychloroquine because we have access to that. In the rest of the world, in parts of the world that don't have access to hydroxychloroquine in particular, they use chloroquine or some of the other anti-malarials that they have access to. But we're fortunate to have hydroxychloroquine, which is much better tolerated from a GI perspective. And the reason we use it is because it's been shown to reduce these flares. So from an organ damage perspective, we certainly prioritize having that on board. And they tend to have patients on hydroxychloroquine or anti-malarials in general tend to have a better response to other therapeutics, again, because of some immunomodulatory effect from these agents. And in general, again, they're safe during pregnancy. They're overall very well tolerated. And the two major things that I want everyone to be aware of when the patient's on hydroxychloroquine is dilated eye exam, which I do yearly. Guidelines mention starting 5 years after being on the drug. I start to build the habit of yearly exam from the moment I start the treatment. And then also QTC monitoring and being aware that these anti-malarial therapies do affect the QTC interval. And so when you're adding other therapeutics, being just mindful of that. Other things that we really think about in the management of all of our patients with autoimmune disease and talking about lupus in general today is all of the things that from especially the primary care perspective need to be kept in mind, and also all of us subspecialists that treat patients with autoimmune diseases, but their cardiovascular risk, their infection risk, their bone health. Of course, many of these individuals end up being on prednisone for extended duration of the time, so their bone health is certainly at risk. Their skincare and having a broad spectrum sunscreen on board and all of the education that goes with that. We definitely focus on fertility and pregnancy management, so especially if there's unplanned pregnancy during a lupus nephritis flare. That's certainly a very high risk for poor outcomes, both in the mom and the baby. And so these are patients that we very closely collaborate with our maternal fetal medicine specialists and very carefully watch and monitor the patient throughout their course of the pregnancy. And then, of course, from a cancer, both the screening for age and population appropriate cancer screening, but also if they develop cancers because of their immunosuppressive therapies, we do need to be very mindful of these complications. And so all of these, what I've talked about with the anti-malarials and these, they go for all of our patients with lupus nephritis. But then specific to class 2, because the actual glom is very often overall preserved, there's just mild mesangial changes, but otherwise the degree of inflammation in the glomerulus is not significant. Up until 2026, we've always had these guidelines saying that if there is nephrotic syndrome, of course, we as nephrologists take on the responsibility of addressing the immunosuppression for concerns such as lupus podocytopathy. But then in the past, we've been saying that if there is no nephrotic syndrome, class 2, we actually defer immunosuppressive therapy to other specialists involved to address that based on the patient's extrarenal manifestations. Well, I'll just mention it very briefly because that study is not published yet, but there is a study coming, and I've spoken with the author, that's showing that very likely this is going to change because we're identifying that class 2 is not as benign as once thought. Because there are still inflammatory changes that are happening at the kidney tissue level. And so if there is no extrarenal manifestation and we don't really do anything for that individual, of course, we're actually increasing the risk of progression of nephron loss in that case. So this might change, but at the moment, again, for class 2, if there is no nephrotic syndrome, a lot of the times the management is based on their extrarenal manifestations. So for the patient in case one, she was started on hydroxychloroquine. She was started also on a low-dose steroid by her rheumatologist for arthralgias. Rash resolved, urine protein excretion resolved actually on hydroxychloroquine, and that just a low dose of steroids for about 4 weeks. And she's really doing phenomenal at this point. She's about 6 months out. She's doing great on hydroxychloroquine only. And at this point, she has no extrarenal changes that would require, escalation of therapeutics. And from a kidney perspective, she's actually doing well on biomarkers that we have available. So on complement levels, on urine studies. And so she's right now on monotherapy of hydroxychloroquine. But now going to something a little bit more complex so that we can talk about the more proliferative lupus nephritis cases. So in this case, we have a patient who's 19 years old, which is a very common, unfortunately, time for lupus to present. These very young, at the prime of their life individuals that suddenly develop autoimmune conditions. She had no known past medical history other than just kind of very well-controlled asthma. And for the past 2 weeks, she's had intermittent fevers, arthralgias, worsening fatigue. She also had a bad sunburn about a month ago that kind of resolved. She's starting to have some swelling in her ankles, which is new for her. And that actually, the ankle swelling was what brought her to the healthcare system. She is in college, doesn't really have any recent travel, doesn't have any alcohol, tobacco, substance use. And there is a family history of mother with rheumatoid arthritis, again, well controlled, father with hypertension, and no known kidney involvement in the family. And you see her medications and allergies, vitals, a low-grade temp. She's actually hypertensive for a 19-year-old woman. That's quite a concerning blood pressure. And then on exam, of course, the biggest concern was that she's actually having some ascites. Her abdomen was a bit distended with a fluid wave. She had some pitting edema. And again, overall, a hypervolemic state for this 19-year-old individual who was quite well up until just a couple of months before. So the labs that were obtained at that point showed that her creatinine has gone from like a baseline of about 0.5 or so just a few months ago for initiation of college to now 1.6. The rest of her BMP is not too impressive. On the CBC, she has a white count of 3.2, hemoglobin 11.2, platelets 110. So all cell lines are slightly low. Transaminases were actually normal, and she has a lot of protein excretion. So her UPCR was 2100, UACR about 1500. And you see her urine microscopy on the right is showing a cellular cast, and these are RBCs. I know the slide is probably very small for you, but these are RBCs. So this was an RBC cast, which is a big concern. So at this point, again, this individual is very concerning for having an active lupus nephritis, actually almost RPG in kind of a presentation. Additional labs showed low complements, both C3 and C4, significantly elevated ANA, double-stranded DNA was positive, anti-Smith was positive. In all of these individuals with a nephritic picture, we always ask for the ANCA testing also because, again, sometimes that changes management and sometimes patients have dual positive antibodies. So it could be that a patient with lupus and lupus nephritis would also have elevated ANCA levels, and those individuals we actually treat a little bit differently. And so we checked that, and unfortunately, she was negative. So her biopsy, of course, we don't even need to think about the question of do we need to do a biopsy or not. Of course, this individual would warrant a biopsy at this point to really see what exactly we're dealing with so that we can really tailor our therapeutics based on that. So the top left photo actually shows that there are 4 glomeruli. These are all very congested with cells. As you see, there are a lot of those little purple dots that indicate inflammatory cells. You don't really saw in the bottom, I've included a normal glomerulus. You see a lot of open capillary loops, that kind of lacy look of it that actually has that whiteness in the background that you can see through these capillary loops in that cross-sectional slide. You don't see that in that top left photo at all. All 4 gloms are very similarly involved. They both have what we would call endocapillary hypercellularity. So all of these endocapillary areas within the capillary loops are full of cells. You'll see another slide below that. That's that's the PAS stain. That's clearly showing us that there is an extracapillary hypercellularity also. So the top photo shows that within the capillary loops, there's a lot of cells, and you don't really see open capillary loops. The bottom one shows that it actually has extended also in this glom to extracapillary hypercellularity, which is essentially that crescent terminology that you're familiar with. And then the bottom photo in immunofluorescence shows that full house terminology that we often talk about when we talk about lupus. And full house is a terminology that has come from poker. I learned about that through my medical journey. But apparently, if you're familiar with poker, it's like 3 of one kind, 2 of another. And so it's usually 3 of immunoglobulins. So in this case, IgM, IgG, and IgA are positive. And 2 complements of C3 and C1q are very classically positive in patients with lupus. So this full house terminology refers to 3 of one kind, these are immunoglobulins, 2 of the complements. And so again, overall, this sample was very concerning for diffuse endocapillary hypercellularity, thickened GBMs, crescents, which essentially gives the patient a diagnosis of class 4 lupus nephritis. So going to the therapeutics of a class 4, which again, as I mentioned to you before, for all of these proliferative lupus nephritis cases, class 3 or 4 doesn't matter. We treat both of them similarly and urgently. So a multi-pronged approach to them would be thinking about their anti-malarial therapy, thinking about all of the lifestyle modifications that we want in all of our patients with glomerular diseases, 100% talking about smoking cessation, exercise, healthy nutrition, a low inflammatory nutrition, the least preservative having nutrition is always what we recommend. Blood pressure management, sunscreen, cancer monitoring, all of those. And again, essentially like the bottom images are actually showing you everything that we had in that table that I showed you before. And then, of course, now we certainly need to also talk about urgent immunosuppression to really dampen that inflammatory response that's happening at the kidney tissue level. So from the immunosuppression side, these are algorithms that as nephrologists we're very familiar with because these are from KDIGO or Kidney Disease Improving Global Outcomes. So essentially a governing body of nephrology globally that comes out with these guidelines based on the available evidence until the moment that they're actually releasing their guidelines. And so from the proliferative lupus nephritis class 3 and 4, of course, the first and foremost is going to be that pulse steroids, which I'll show you on the next slide. We're actually utilizing lower and lower doses in the nephrology field. But then also, in addition to the steroids, we certainly need to add on additional therapeutics for that multi-targeted approach. But just a brief note about the steroids. From both the pulse and the oral, we're actually utilizing much, much lower. So for pulse, these are individuals that, again, are at the prime of their life, years of potential immunosuppression ahead of them. And so we're actually trying to preserve their exposure to steroids. So on the nephrology side, we're now at a point that we're recommending instead of 1 gram for 3 days of methylprednisolone, we very often utilize either 250 or 500, depending on how severe the patient's inflammatory state is. But usually we actually just do 250 or 500. And it could be 1 to 3 days. It doesn't necessarily have to be the pulse dose is always 3 days. And then on the oral side, as you see, there are 3 kind of approaches that we can have to the oral dosing of their immunosuppression. So for somebody, again, with class 4, very inflammatory, sometimes I still go with the standard dose, which essentially starts with the 1 milligram per kilogram of body weight for the first couple of weeks or so, and then tapering down very rapidly from there. But for patients with a little bit lower response or lower that activity index, for example, on that biopsy sample, sometimes we do actually go with the moderate dose or reduced dose. So again, just keeping that in mind. And again, my goal always is to, like, within the first 6 months of therapy, to have that steroid down to less than 5 milligram. Very often we just get it down to 2.5 milligram per day, unless there are extra renal manifestations, like joints sometimes need higher doses of steroids for response. And so in that case, we collaborate with our rheumatology colleagues. So then beyond the steroids, as I mentioned, we very quickly want to actually bring in that multi-targeted therapy. And what do we talk about for multi-targeted? For the longest time, we were actually limited to just these two that I've highlighted here, either cyclophosphamide or mycophenolate-based therapy. And there have been, for the sake of time, I'm not going to go through all of the studies that differentiate kind of response between these two, but there have been studies that have shown that IV cyclophosphamide is just as effective and with lower side effect profile compared to PO. So we now, if we want to do cyclophosphamide as nephrologists, we do IV. Outside of COVID era, which we switched many of our patients to oral, just kind of like for easy termination. But then the alternative is mycophenolate-based therapy, which actually has shown by clinical trials, for example, Ulm's trial, that was a very well-known one in nephrology, that showed the lack of inferiority of mycophenolate compared to cyclophosphamide, with a much better side effect profile, of course. And also for certain ethnicities, for example, our Hispanic patients, actually mycophenolate was superior to cyclophosphamide. So now majority of our patients, unless we really have to, they're in the ICU setting, we really have, like, we want to actually get that inflammatory response quickly down. In those patients, we still do cyclophosphamide, but in majority of the cases, our lupus nephritis management has now moved to mycophenolate-based therapy from kind of that initial decision between those two. So we start the steroids, we start one of those two, mycophenolate or cyclophosphamide. And then there comes a time, and that time has now become very early on after diagnosis. So up until about a year ago, the guidelines would say, and many nephrologists and rheumatologists would follow those guidelines, saying that we allow those two only to work for about 3 to 6 months. If we're not getting where we need to get to, then we add on the third agent. Now, everyone's on the same page that in those few months of waiting, we're actually having more and more nephron loss. And so in order to prevent that, we're actually moving more forward to triple therapy very quickly as soon as the diagnosis is made. And so what are the two options for triple therapy? It could be B-cell driven or CNI therapy, calcineurin inhibitors, which are T-cell therapeutics. So on the B-cell side, and I'm just going to go a little bit more quickly over the course of the next few slides, because these are, again, more fellow level conversations, but just so that you're aware of which therapeutics we're actually offering now. From a B-cell targeting therapies, we have B-cell depleting agents and also B-cell activation inhibitors. On the B-cell depleting agents, of course, you're familiar with rituximab. I don't know if you're familiar with ofatumumab and obinutuzumab. These are the newer agents, especially obinutuzumab. I'll show you why we're a lot more excited about it than rituximab. And then there are also medications that are anti-B-cell activating therapies. And the one that's currently in therapeutics is belimumab. So I'll show you some studies as far as that goes. And of course, combination of these is one area of investigation, and that's the trial that we have at UC Davis and many other parts of the globe. And that's an agent called ianalumab, which again is investigating combination of these two aspects, both B-cell depletion and activation therapeutics in one molecule. And that's currently under investigation. So very briefly, just showing you all of the studies across the time that have looked at rituximab for lupus nephritis. And they've really shown that rituximab is in observational studies, could potentially have a signal towards positive response. But then in one major clinical trial called LUNAR, the one in the purple, it showed that it actually did not have a positive response. So everybody kind of lost hope for anti-CD20 therapeutics in lupus nephritis. But then looking back, it was identified that patients that did have a response, those were the ones that actually had the deepest B-cell depletion. So with that came the thought that if we could actually get to a much better B-cell depletion, could that actually then have a positive response, and we could actually bring the anti-CD20 biologics into our therapeutic armamentarium for lupus nephritis? And the answer was yes. So that's kind of like type 2 of these anti-CD20 therapeutics is obinutuzumab, which so in rituximab, it's a kind of a hybrid monoclonal antibody. It has a murine mouse component to it. And a lot of people actually form antibodies against that. And so it kind of stops the drug from being therapeutic. Obinutuzumab is fully humanized. So the monoclonal antibody is completely from a humanized glycoengineered source. And so it actually is much more effective. Of course, there is no head-to-head comparison with rituximab in the same population. But looking at the data that we had from LUNAR, comparing it to the study that looked at obinutuzumab, we know that it can reach to a much deeper B-cell depletion and much faster. So the study that looked at that, Nobility was their phase 2, Regency was their phase 3 that published just actually about a year ago, February of 2025. And it showed that obinutuzumab actually in lupus nephritis, again, had a significant decline in proteinuria compared to placebo. And all of these were on standard of care. So all of the patients were on prednisone, their antimalarials, and mycophenolate-based regimen. So added on obinutuzumab compared to placebo to that background led to a better proteinuria response. And of course, as you can see, all of the biomarkers like C3, C4, anti-double-stranded DNA all improved. And so with that, now FDA has approved obinutuzumab for lupus nephritis as of just a few months ago. Now, looking at the BAF side, and for the sake of time, I'm just going to show you just the results. BLISS-LN was a study that looked at belimumab, which is an anti-BAF inhibitor, which is again stopping the activation of B cells. And that also showed that in the background of standard of care on mycophenolate or cyclophosphamide-based initiation, adding on belimumab also led to positive response and better kidney-related outcomes, and overall led to their FDA-approved status. So those are on the B cell side, but there are also patients that actually only have kidney level and they have a significant amount of proteinuria, and we know that they might actually respond better to our calcineurin inhibitors. So our calcineurin inhibitors are actually agents that, in addition to their inflammatory modulating response, that they actually work on cytokines and through a T cell mediated effect, they also stabilize the podocytes themselves, so that the cytoskeleton of these podocytes, and they actually have a proteinuria response that way too. So looking at the two sides, we have our old calcineurin inhibitors like tacrolimus and cyclosporin. The new kid on the block was voclosporin that actually has a much better metabolic profile, so not as much diabetogenic, and the diabetogenicity of tacrolimus is not there. The hirsutism, kind of gingival issues, and all of the concerns about cyclosporin is not there. And we don't really need to actually monitor trough levels. So it's a much easier therapeutic drug. And it's now also FDA approved because of the positive response on both GFR preservation and proteinuria reduction in patients with lupus nephritis. So just putting all of that together, this individual in case 2 was started, of course, on the hydroxychloroquine, had their pulse steroids, switched to oral steroid, moderate doses chosen for her. She was started on the mycophenolate. Again, we slowly ramp it up to the 1,000 goal range BID. And for the multi-targeted therapy, we kind of like hit a couple of challenges. She was initially not interested in Benlysta, which is an injection medication. We started voclosporin, but she had adherence issues, again, in college, and taking 6 tablets a day in addition to everything else was just very challenging for her. And so we switched to obinutuzumab, which is just an infusion every 6 months. And it actually is now maintaining, and she's actually in partial remission at this point. Just a very brief thing about class 5, as we talked about before, about 5 to 10% of the patients have mono class 5, like not combined with everything else. And for those individuals, again, we base it on the nephrotic syndrome. If there is nephrotic syndrome, of course, we escalate the therapeutics. And some patients respond to the anti-CD20 therapeutics. Some respond a little bit better to calcineurin inhibitors. Some actually respond better to multi-targeted even more. So we actually do quadruple therapy for both combination of B-cell therapeutics, T-cell therapeutics, as well as the mycophenolate-based regimen that they're on, to really get the disease under control, and then we can actually peel back some of these therapeutics. On the maintenance side, I just want to let everyone know in the room that this is a disease that's going to have a very, I always tell all my patients and the fellows that lupus tests our patients. And so lupus is something that the treatment is going to take a while to respond. And then also after they respond, if we withdraw the therapeutics at that point, they will have a flare because at the tissue level, histologic activity is still happening. And so for many of these patients, we do minimum of 36 months of therapy, so 3 years of therapy minimum, but many of the patients actually have 4, 5, 6 years of immunosuppression. And again, as I mentioned, sometimes if I have concerns that there might be tissue histologic activity still ongoing, we actually do another kidney biopsy right before immunosuppression withdrawal. And with that, I just wanted to mention that again, early detection is the key. And again, multi-targeted therapy is becoming a major part of our therapeutic approach to these individuals. Future is going to be probably very different. In this talk, I didn't mention anything about CAR-T therapy, CAR-AA therapy, which is actually more focused on autoimmune aspects of these targeted engineered cell-based therapies. And all of that is very likely going to be a part of our autoimmune management in the future. And with that, I thank you and open to any questions or comments.
Thank you so much. It was a great talk. If you have any question, please press and hold the microphone in front of you. While we're waiting for the audience, Dr. Wiegley, if I may ask a question, where do you see liquid biopsy going forward in the management of lupus?
Yeah, that's a great question. I mean, so far we've actually been kind of calling just the urine microscopy liquid biopsy. That terminology might kind of change. There are some labs kind of working on urine proteomics and kind of commercially available more intensive urine studies that can help us with identifying inflammatory biomarkers in the urine. And so in the future, the terminology of liquid biopsy might actually go to that. There are already some kind of opinion-based study, published articles that mention that. So I think the future of urine, liquid biopsy probably will entail a lot more than just microscopy. At the moment, though, it's just limited to urine microscopy from commercially available in all nephrology clinics.
Thank you. Any questions from the audience?
I had a question.
Please, Dr. Hani, if you could press and hold the microphone.
Is it working?
Yes.
Okay. So I'm with the rheumatology department, and thank you for the talk. It's really nice to sort of see, the nephrology guidelines and where they're coming from. My question was about class 2 lupus nephritis. So the current guidelines are obviously for extra renal manifestation, you choose agent based on that. Are there any recommendations, especially if they have hematuria or some inclination of kidney involvement, to choose one agent over the other, like mycophenolate over methotrexate or belimumab over anifrolumab, something like that?
Yeah, that's an excellent question, and I'm so glad you were in the audience too, because I actually just gave this a little bit different version of lupus nephritis talk to our rheumatology colleagues, and this question again came up because this is again a part of that kind of collaborative work with our rheumatology colleagues. So thank you for that question. Yes, so if there are other concerns from a kidney perspective, because again, if for example there is ongoing hematuria, but in the biopsy we only see class 2, which hematuria shouldn't really be a part of class 2 necessarily, because usually we see hematuria when the capillary loops are involved. So if it's just mesangial on the biopsy, but the patient still has acanthocytes in the urine, I question the sample bias, the sampling bias in that biopsy. because we don't necessarily want to always go back and like take another piece of that poor kidney and immediately have another biopsy. A lot of times we're just limited to that sampling bias, and we just kind of treat the best that we can. So if in a patient that has biopsy proven class 2 only, but perhaps like we missed a lupus vasculitis or other kind of possibilities for having RBCs in the urine, true acanthocytes in the urine, or isomorphic acanthocytes from like a vasculitic perspective. If they actually have that in the urine, then I would actually tailor therapeutics to something that we know would be more effective for the kidneys. And things that we know is, for example, methotrexate has not shown efficacy for kidneys. We don't know if it has penetration to the kidneys or what. But methotrexate actually, when there is kidney involvement, we always prefer things like mycophenolate, even over azathioprine, and definitely compared to methotrexate. As far as your question about belimumab versus anifrolumab, anifrolumab actually, from a lupus nephritis perspective, their phase 2 was a little bit of a negative study, although there's still a lot of hope that there is a role for this agent and that kind of class of therapeutic, these anti-interferon type therapeutics in the realm of lupus nephritis. It's just that the thought is that maybe the dosing was not appropriate, and the patients with lupus nephritis, similar to belimumab, they actually need a higher dose of anifrolumab. So in their phase 3, which is the TULIP trial, they're actually investigating the higher dose right now, and that's under investigation. So we'll find out. But at the moment, if they're class 2, but they're having other concerns from a kidney involvement perspective, I would probably prioritize MMF and then belimumab over the other 2 agents.
Thank you.
All right, it's almost 1 p.m. Thank you so much, Dr. Wiegley, for your time today. It was a great talk. Please log on to the EVMS CME website to claim your credit today, and we'll see you all next week. Thank you so much.
Great. Thank you for having me. Have a great rest of your day.